My name is Mathieu Poirier. I'm the co-director of the Global Strategy Lab, and I'm really excited that we'll be highlighting 3 projects today that are completed by the AMR Policy Accelerator team. And it gives me great pleasure to introduce our 3 speakers today. I'll start with Michèle Palkovits, who is a policy advisor with the AMR Policy Accelerator, where she works with governments and international organizations to develop evidence-based and locally adapted policy solutions to solve AMR challenges. Her background includes global health policy and governance research and experience in health systems development with NGOs operating in West Africa. Next, we'll be hearing from Fiona Emdin, who is a veterinarian and research fellow at the AMR Policy Accelerator, who supports the lab's antimicrobial resistance policy research. Her previous policy and research experience focused on improving One Health approaches to global food security through climate-smart agricultural technologies and infectious disease surveillance. And finally, we'll be hearing from Shajoe, who is the AMR Policy Accelerator's international legal advisor. He's an international health attorney providing strategic advice on the design of evidence-informed strategies to address transnational health threats. Shajoe has significant experience advising governments and NGOs in the Caribbean and Latin America on non-communicable disease law and policy. So those are the 3 speakers for today. And these presentations are going to be just 3 examples of the research and advisory work that we do at the AMR Policy Accelerator, as well as how we champion gender and equity through our work. The AMR Policy Accelerator is an initiative of the Global Strategy Lab that's focused on providing context-specific AMR research and policy guidance to support clients' AMR policy needs. And before we get started on the presentations, I would like to invite all the participants and folks watching to add any questions you may have to the Q&A box as people are speaking or immediately afterwards. And we'll try to address as many as possible in the second half of this hour as we have a Q&A session. So without further ado, I will start us off on the first panel. And we'll be hearing from Michèle Palkovits on antibiotic access and use in migrant and refugee populations. Take it away, Michèle.
Thanks so much, Mathieu, for that introduction. I'll just share my screen. If someone can let me know that it's working, just with a thumbs up. Great, thank you. All right, so good morning, everyone. I'm delighted to be able to speak today and contribute to this conversation with my lovely colleagues about the importance of equity. It's a great way to bring awareness to World Antimicrobial Awareness Week and to celebrate the launch of the AMR Policy Accelerator. So today I'll be speaking to you about a project that the Policy Accelerator completed earlier this year to investigate antibiotic access and use in migrant and refugee populations. This was in the cadre of WHO's Health and Migration Program's Global Evidence Review on Health and Migration series. And the WHO asked us to fill a really important gap in knowledge and to provide recommendations for action. So at the outset of this project, what we knew was that some of the principal drivers of AMR include the misuse and overuse of antibiotics, and that poor access to antibiotics, aside from being a very important human rights issue, can also facilitate the spread of disease. We also already knew that the conditions under which migrant and refugees leave their countries of origin and transit to host countries can place them at higher risk for infectious disease and drug-resistant infections, and that the cumulative effect of conditions are compounded on arrival into host countries, where they're likely to have much poorer access and use of healthcare services. What we didn't know, however, is how migrants and refugees experience access and use of antibiotics. So with that background, the WHO asked our team to set out to capture the evidence on migrant and refugees population access and use of antibiotics, to map barriers to said access and use, and finally to provide some recommendations for action at both the national and global levels. So in today's presentation, I'm going to walk you through the Policy Accelerator's approach to answering this type of question, and really focus on some of the important findings of this work when we think about their value add to policymaking. So with the client, we collaboratively designed feasible research methods that drew on some of the highest quality standards in academic research. So given the allotted time frame, we revised the problem and research questions so that would be feasible, and we plan to perform a scoping review. So we conducted searches of the peer review literature. We also reached out to organizations in the field for additional evidence sources. So this was MSF, the IOM, some UN branches and country and regional offices. We also introduced some analyses to better understand the findings, including a gender analysis. So considering the implications of sex and gender for AMR, as Fiona will be discussing later today, this is something we strive to consider in all of our projects at the Policy Accelerator. We also drew on the academic literature to inform how we'd analyze the evidence. We structured our findings around an access framework, which you can see at the bottom of the screen right now. And I'm going to talk a little bit more about that framework later on when I'm discussing the findings. So jumping into some of the key findings, I'm going to highlight some particularly interesting findings today around appropriate use of antibiotics and barriers to access. So appropriate use findings, we organized our findings on appropriate use into both prescriber side and patient side forms of use. We find that antibiotic overprescribing is common in the general population. Unnecessary use has been documented to reach up to 89% in some US settings. But there's some evidence to suggest that providers might actually be more likely to unnecessarily prescribe antibiotics to migrant and refugee patients than to native-born populations. And we find that unnecessary prescriptions are often associated with prescriptions for conditions that are unlikely to be of bacterial origin. In Europe, specifically in Germany, overprescription was found to be primarily associated with diagnoses of acute bronchitis, whereas a study performed in Uganda showed unnecessary prescriptions were primarily dispensed for malaria. Prescribers perceive diagnostic uncertainty, parental expectations, and concerns with assuring follow-up as some of the principal drivers of unnecessary prescribing. So looking at appropriate use on the patient side, we looked at self-medication. Studies revealed widespread evidence of self-medication among migrants living in high-income countries, and between 19 and 45% of migrants reported having previously obtained or used antibiotics without a prescription when a prescription was required. Among migrants having recently used antibiotics, up to half in some contexts had self-medicated. And this is an interesting instance where the additional gender analysis revealed an important finding. So studies of Latin American migrants in the US highlighted the role of gender when it came to informal sources of antibiotic acquisition. Women were more likely to cross the border for and import antibiotics. They were often perceived as being responsible for obtaining and administering medicines. And those communities often rely on female social networks for supplies and treatment advice when it comes to self-medication. Looking at barriers to access and use. So we mapped the barriers to access and use for migrants and refugees onto a continuum of care to depict where interruptions might occur for these populations in the care cascade, from a health need arising all the way through to receiving adequate and quality care. And rather than walk through all of these different barriers, because there's a lot of them, I'm going to just zoom in on a couple to give you an idea about the actionability of these barriers. So first, looking at barriers to availability. At this point in the care continuum, the patient wants to be cared through the formal system and may actually seek out care, but is unable to physically reach it. So we find that this can be due to wait times and service availability. And there's evidence to show that access to a regular GP improves adherence to antibiotics. Then looking at barriers to the affordability of care. At this point in the care continuum, a patient successfully reaches care, but they can't actually go through the process of utilizing that care. And a barrier we find here includes lack of health insurance. And this typically arises in cases where migrants are either not entitled to care because some countries don't provide care coverage for undocumented migrants or asylum seekers, or they're just unaware of their legal entitlements. Looking at a couple key implications of the finding of this project. So first, access and conservation are linked. We often talk about access and conservation as being two distinct strategies towards addressing AMR and describe them as being at odds with one another. So improving access risks undermining conservation, and increasing conservation can constrain access. But our findings suggest that access can sometimes be beneficial to conservation, as barriers to formal care can increase the likelihood of inappropriate use. So studies repeatedly show that barriers to the formal care system cause migrant and refugee populations to seek out antibiotics through informal networks, driving self-medication. In a study of non-prescribed antibiotic use among Chinese migrants in Australia, participants reported no perceived barriers to using healthcare services were less likely to use non-prescribed antibiotics when compared with participants that had reported at least one barrier. And in another study of Palestinian refugees in Jordan, these refugees were almost twice as likely to self-medicate and buy antibiotics directly from pharmacies if they perceived wait times to be long. We also find that barriers to formal medication can also be barriers to self-medication. So our findings support existing analyses that migrants in the US have a hierarchy of preferences for sourcing antibiotics, from what's perceived as least risky to the riskiest in terms of quality. And migrants do try to obtain antibiotics from sources that they trust. Refugees and migrants report most often sourcing non-prescription antibiotics during trips to their countries of origin. For documented migrants who can travel back, this is an option. But for undocumented migrants who already have poor access to formal care in the host country, vulnerability can compound vulnerability because they can't go back to their countries of origin and are driven to self-medicate with riskier, less quality assured drugs. For the second key implication, our findings support the shift away from a one-size-fits-all strategies towards more precision interventions because norms, beliefs, perceptions, and behaviors vary and can be imported from countries of origin. So AMR policies and interventions that overlook this kind of variation between groups can risk exacerbating inequitable health outcomes for these populations. So norms, beliefs, perceptions, and behaviors vary. Among some migrant communities, antibiotics are perceived as being too strong, whereas in others, they're perceived as being too weak, which leads to underuse in one context and overuse or self-medication in another. And in yet another context, we find that adapting to stricter access in a new host country depended on beliefs around previous exposure to antibiotics. So Syrian refugee mothers adapted well to stricter practices in Netherlands when it came to their children because they felt their children didn't need antibiotics to combat illness. On the other hand, they felt that they themselves did need antibiotics since their bodies were so used to them from repeat previous exposure. This exemplifies a need for contextualized approaches and research into specific community that's being targeted. We also see that norms, beliefs, perceptions, and behaviors can be imported. So migrants born in countries where antibiotics are available over the counter are significantly more likely to self-medicate than those born in countries where access is regulated, is more strictly regulated. Another study shows that patterns of behavior replicate across multiple host countries. So when we compare use between the host populations of 2 European countries and migrant groups, migrants' countries of origins were associated with drug use. So that's to say that in both host countries, Chinese migrants had lower rates of use than the host population, while Moroccans had higher rates of use. So as a policymaker, what can you do? Based on some of those key implications, national policymakers should focus on first, improving access so as to also improve use. And 2, to embrace precision targeting. Make sure you understand the population in your context because population beliefs, perceptions, and behaviors can really make or break a public health response. And a full list of our recommendations for policymakers is available on the WHO report that's pictured here. And with that, I just want to give a quick shout out to the team that made this project possible. So thank you very much to everyone on the screen. And thank you everyone for your attention today.
All right. Thank you so much, Michèle, for that fascinating presentation. It's now, again, my pleasure to introduce the next speaker, who is going to be Fiona Emdin, and presenting a talk titled Gender and AMR Inequities. Take it away, Fiona.
Awesome. Thanks so much, Mathieu. Can everyone see my screen? Great. So good morning, everyone. I'm very happy today to be talking about gender equity and AMR inequities, and specifically why groups working in AMR policy should apply a gender lens to their assessment of global AMR research, policy, and action. And I did want to highlight this work was undertaken as part of a project that we completed at the AMR Policy Accelerator in partnership with the International Livestock Research Institute in Nairobi. So as a quick summary of what we'll be going through today, first, I'll be talking about what the current approach to research, policy, and action taken against AMR has been. Next, I'll be talking about how gender can drive AMR in a few key areas. I'll also be talking about why gender should be a key consideration of our approach, especially any action that being undertaken at a global level to address AMR. And finally, I'll be discussing what steps could be taken to help address the current lack of gender equity in AMR. So to start, let's briefly talk about what the traditional approach to AMR has been. So I think most people would agree that there recently has been a big focus on a One Health approach. So that's coordinated multi-sectoral action, so across the human, animal, and environmental sectors. The actions that have been taken against AMR have been focused on what I would call traditional drivers of AMR. So that's things like the overuse of antibiotics in agriculture. And most policy and action approaches fail to consider social and economic drivers when addressing AMR. And one of the key inequities that's not considered by traditional approaches is gender equity. And this is despite the fact that gender equity is a core aim of the United Nations Development Assistance Framework and one of the United Nations Sustainable Development Goals. So despite gender being listed as a priority by other national groups like the United Nations, it's rarely addressed in the AMR space. So first, if we look at AMR research, results are rarely stratified by gender. And I think one review found that even among human AMR publications that are actually looking at social determinants of health, only about 2% are actually considering gender. Within policy research as well, AMR policy outcomes are rarely disaggregated by gender, and the gendered effects of AMR policies are rarely explored as well. If we look at national action plans, as well, most national action plans on AMR are not really considering gender specific or related policies, and very rarely do they even list gender as a driver of inequity in AMR related outcomes. And then finally, if we look at policy, most policy interventions also do not mention or consider gender. And there's a potential for these policy gaps created from insufficient consideration of gender that will produce unsustainable policy responses and even may worsen the challenges posed by other known AMR equity gaps. So that's things like Michèle just mentioned in her project. So poverty, migration, hygiene, all of these things can be interlinked. So we know the current approach to AMR across research, policy, and action doesn't really consider gender, but why should it? So we found in our research at the AMR Policy Accelerator that gender impacts AMR in two key areas. First, gender impacts antimicrobial access. And second, it also impacts exposure to AMR pathogens. And this isn't to say that gender doesn't act to drive AMR in other ways, but this is just what two big areas that came up a lot in our research. So let's explore some examples from these two areas across each of the One Health sectors. So starting with how gender can impact antimicrobial access, if we look at the human sector first, we know that gender can compound existing barriers around access to antimicrobials, and generally globally, women are less likely to have access to antimicrobials compared to men. Also, globally, women are more likely to be prescribed antibiotics unnecessarily compared to men, even when we account for gender differences in disease incidence. And from the animal side, women's empowerment has also been linked to improved access to veterinary care and medicines like antimicrobials. So any gender norms that are going to limit women's access to veterinary care and services are going to limit their ability to raise healthy and productive livestock, which in turn will limit their ability to have improved household income and nutrition. So there's a clear overlap here with some of the other United Nations Sustainable Development Goals, as I previously mentioned. And women livestock producers are less likely to report purchasing medicines and vaccines, so things like antimicrobials, for animals they own or manage, and they're also less likely to access animal health service providers like veterinarians. And then similarly, from an environmental standpoint, women are less likely to report having access or knowledge on herbicides and insecticides, which can act as environmental mediators of AMR. And they're also, just like in the animal sector, less likely to have access to plant health specialists. Interestingly, also, although farmers who are men are more likely to report higher rates of pesticide use, women appear to be more vulnerable to pesticide intoxication, which may be due to less education around safe pesticide use. Similarly, if we look at on the AMR exposure side, exposure to AMR pathogens may be driven by differences in gender norms as well. So on the human side, traditional masculinity norms have been used to explain why men are more likely to delay treatment seeking and less likely to follow treatment guidelines. And this may explain why they might be at higher risk of acquiring some drug-resistant infections. So that's things like chloroquine-resistant malaria, multi-drug-resistant gonorrheal infections, and multi-drug-resistant tuberculosis as well. And then in the animal sector, small-scale livestock production is led by women in most countries. And this is probably an important route of AMR exposure that's often overlooked and underlooked as well. So if we look at studies that have done on AMR enteric pathogens in women and children, these studies have actually found that AMR enteric pathogens are at higher rates in women and children, and this may be due to increased contact with animal manure and slaughter products in these areas. And then finally, if we look at the environmental sector, women have reduced access to clean water and may be at higher risk of both waterborne pathogens and AMR. And this is because girls and women are primarily responsible for water collection and community sanitation, and they may be more involved in maintaining family sanitation needs as well. So things like cleaning shared toilet spaces. So I hope these examples have kind of shown that gender can be a significant driver of AMR inequities, but let's talk about why gender should be considered as well in the research, policy, and action that we're working on in AMR. So this is kind of the so what of this presentation. So it's important that we're considering gender impacts of any AMR policy because we know that AMR can be inequitably distributed across genders. And I think most people are aware of the fact that AMR is inequitable in its effects. And for example, we know that the greatest burden of AMR often falls on low-income countries. So gender is just another area where the impact and effects of AMR are inequitably distributed. And hopefully, again, the examples we've just explored on gendered impacts on access to antimicrobials and AMR exposure have demonstrated that. As I previously mentioned, if we don't consider gender equity in AMR policy, this may result in gendered AMR policy outcomes, which in turn could worsen existing gender drivers. And this is what the figure on the right-hand side of this slide is showing, just as potential negative feedback loop that could happen if we don't consider gender in what we do. And as I mentioned earlier, the inequitable impacts of AMR policies are rarely explored, and especially for any policies that are limiting access to antimicrobials or impacting gender norms or gendered activities or occupations, we really should be considering the potential inequitable gender consequences of these. So what can be done to address this inequity moving forward? So first, let's talk about some general actionable areas that the AMR Policy Accelerator has identified as areas that could be targeted to improve gender inclusion in AMR. So first, gender should be at the foundation of all global research, policy, and actions targeting AMR. Gender impact should be considered in any AMR mitigation actions that are being advocated for, and gender equity should be included in reports targeting policymakers. Also, groups should be highlighting this inequity by identifying gender as a knowledge gap and calling for research that specifically tracks gender and equity impacts in AMR. They should also ensure that gender is included in the outputs, especially those geared at other researchers and policymakers operate in the AMR space. By interrogating policies that are limiting access to antibiotics for potential inequitable consequences, we can help prevent against gendered outcomes in AMR in any policies or actions that we're advocating for. And these are some key areas that the AMR Policy Accelerator is going to be targeting as well. And now let's talk about some more specific actionable areas that researchers and policymakers working in the AMR space can help target as well. So first, we need tools to include and assess gender in AMR policy. And right now, as I mentioned at the beginning of this presentation, there's few gender and AMR specific data, research, and tools available to policymakers. But tools and frameworks, I think, are especially useful because these can be used as codes of practice to guide policy and support action on gender and AMR. And they can also improve the accountability of AMR policy addressing gender. As well, similarly to what Michèle was mentioning, these tools can also be useful to help align AMR policies and national action plans with other United Nations Sustainable Development Goals. And as I mentioned throughout this presentation, there's clearly a lot of overlap in these areas. Next, we also need to prioritize gender in the next generation of AMR national action plans. So potentially, because there is such a lack of data available, policymakers working on the next generation of national action plans may have to conduct some situational analyses to gather baseline data on gender and AMR. And baseline data can help to identify and target local gender inequities related to AMR and contribute to the development and execution of gender-related or responsive policies. And third, we should be interrogating gender in any AMR surveillance and mitigation. We should be integrating gender into any AMR surveillance and mitigation policies that we're developing as well. So again, to supplement this lack of data that we have and to strengthen the benefits of using gender tools and frameworks, we should be collecting gender data as part of our routine local AMR surveillance processes. This is going to improve our understanding of the effects of gender on AMR, but also, again, enhance alignment with some of those other global priorities that we've already talked about. And finally, we need to support research to identify and fill the key knowledge gaps related to gender and AMR that we have identified. This research will help drive links to gender norms and their intersections with other socio-demographic and socioeconomic conditions. And findings from this research can contribute to improved and tailored policy interventions for populations going forward. So over the course of this presentation, we've explored what the previous approach to AMR has been, how gender can impact AMR, why gender should be a consideration of AMR policy, and what steps can be taken to address gendered consequences of AMR research, policy, and action. What I hope you'll take away from this presentation is that we know AMR is inequitable in its effects, including in its impacts on different genders, but gender is not often a consideration of people working in this space. So to address this inequity, we should be highlighting this as a knowledge gap and applying a gender lens whenever we're assessing any research, policy, and action targeting AMR. Because AMR is a multidisciplinary One Health global challenge with inequitable effects, only solutions that are equitable are going to be sustainable. And policymakers, I think, have an important role to ensure continued commitment to gender equity going forward. By prioritizing gender in national action plans and in further research, this will be crucial to helping improving our understanding of the complex relationships that drive AMR across the One Health sectors related to gender. And we at the Policy Accelerator will also be working to address some of the actionable areas that I've identified in this project going forward. And thank you so much for listening, everyone. And I'll take any questions during that question period following Shajoe's presentation.
Thank you so much, Fiona, for another excellent presentation. And it's now again my pleasure to introduce the third and final presentation before we turn to questions. And I'll again encourage you, if you have any questions, please do put them in the Q&A box. We'll be happy to address them after we finish. So finally, it's my pleasure to introduce Shajoe, who will be presenting on the international legal dimensions of AMR. Over to you, Shajoe.
Stop sharing. Thank you, Matthew. I'm just trying to pull up this presentation. Yes. Thank you, Matthew. Good morning, everyone. Today, I am going to be talking about the international legal dimensions of antimicrobial resistance, specifically looking at how international law can promote health equity in global AMR policies. This presentation, I should say, is based on an analysis that the Policy Accelerator did for the Ministerial Alliance of AMR Champions, as well as an analysis we led with a constellation of global AMR actors. In this analysis, we looked at how the new pandemic treaty could address AMR. And as a part of that, we also looked at the extent to which equity could be featured in the design of that instrument. Now, in opening this conversation, I think it is important to recognize one thing, and this is that we're at a moment, right? It's a very big moment, perhaps brought on by the COVID-19 pandemic, where there seems to be unanimous, albeit very high level agreement, that equity should be an essential ingredient in global health policy making. Similarly, we seem to have some idea of what that should look like. I think that it is, however, less clear, what kind of tools we have at our disposal and how we can use those tools to make this a reality for global health more broadly, but also AMR. Today, I'm going to be talking about three things. Number one, very briefly, the global AMR policy challenges. Number two, the rationale for promoting equity in global AMR policy. And finally, number three, how and why we can use international law to promote health equity in global AMR policy. And here, I'll reference the new pandemic treaty being negotiated by the Intergovernmental Negotiating Body through WHO, because it really provides a unique opportunity to practically illustrate how we can use international law to promote health equity for AMR. Now, when we discuss global AMR policy challenges, we're usually referring to challenges within four specific areas: prevention, innovation, conservation, and access. For prevention, we know that we need to increase surveillance capacity, and we need to develop international benchmarks for measuring this capacity, as well as developing methodologies to guide governments in identifying and managing infectious disease risks, both at the national and subnational levels. For innovation, we know we need new antimicrobials because resistance is on the rise, and so we need effective antimicrobials. That means that we need mechanisms to finance the research and development of these tools. But there's also the issue of conservation, right? Since the use of antimicrobials drive resistance, and this is a finite shared resource, we need international standard rules governing how these drugs are used. And finally, there's the access challenge. We know that the current IP system, which grants exclusivity to new drugs, that significantly affects access because there's no price control. And so access is therefore dependent on who can afford these drugs if they're developed. And these are some national AMR actions which we found to be at globally suboptimal levels and need to be addressed. But if we look very closely at these 4 policy areas, we see that they all have a dimension that touches and concerns equity. And this brings us to the second part of the presentation. That is, why is equity so important for global AMR policy? Here, I would argue that we cannot solve AMR's policy challenges without an equitable approach, because the challenges exist in a construct of systemic global inequity, and they are interlinked. So we know that health disparities exist among and within countries. And so to be effective, AMR policy has to be tailored towards the challenge. Otherwise, the core of the issues will likely remain unsolved. For instance, funding, research and development for new antimicrobials, that's good. But if the drugs are developed in a system where patents and exclusive rights dictate their price, only countries with resources will be able to access them. So while we would be solving one policy challenge, that is innovation, the issue of access would still be unaddressed. Similarly, developing uniform, consistent stewardship rules is good. It means we have a standardized way of regulating the use of antimicrobials across countries. However, if all countries do not have the technical capacity to implement these rules, then the policy outcome, reduced antimicrobial use, which we know is good and we need that, might not be achieved. So by and large, we see that across the spectrum of policy initiatives needed for antimicrobial resistance, issues of inequity persist, such that an equity-informed perspective is not only valuable and important, but I would argue necessary. So we've unpacked the global AMR policy challenges and identified that equity must feature in the design of global AMR policies for them to work. The next step then is to look at the tools we have to make this a reality. How do we go further than just recognizing the importance of equity? One of the most opposite tools we have at our disposal is law, more specifically international law. We need to change the global governance structures to address the root causes of AMR. And law is a very powerful tool. It can enable the conditions needed for equity to be realized. And we do recognize that it can constrain those conditions and negatively impact equity in some instances. But we have examples where law has been used as health intervention. So we're talking about vaccine mandates, requirements for face masks, travel restrictions, social distancing. Law has been used to define the powers and rules and boundaries that govern health agencies and systems. For example, rules that prohibit discrimination in the provision of health services, rules prohibiting hospitals from turning away people because they don't have health insurance. Those are all examples of how law has been used to advance health equity and protect public health. We do recognize that there are some laws that were not necessarily designed to affect population health, but they do. For example, the TRIPS agreement, right? It incentivizes people to make new drugs because they get that exclusive right. However, it takes it back on some issues like vaccines and antimicrobials, where those are, essential goods that we really need, and we need them fast. And, in order to ensure equity, we need everyone to have access to them, and some countries don't have the resources to access them, right? So there's that challenge. However, I think by and large, the power of law to shape equity is underscored greater than it's not. We have examples of how international law has been used to drive health equity, and this is primarily in the climate and environment space. For example, both the Montreal Protocol and Minamata Convention mandate states, wealthier countries to contribute to a fund or a financial mechanism that supports LMICs in the implementation of their treaty. This is an example of how a treaty can recognize a resource disparity, recognize that there's a need to solve a global challenge, and organize and create an architecture in which equity can be manifest, right? So we have good examples. And when we look at the language used in the UNFCCC, we see that they use a may versus a shall in the earlier two treaties. However, that is just a way for negotiators to play around with the language, because by and large, the treaties are recognizing that equity is important and actively designing provisions that promote this. So the Policy Accelerator has identified several options available to treaty negotiators and countries to design an equitable treaty that addresses AMR. Number one, a mandate for the treaty to adopt a human rights approach to pandemic preparedness functions. But beyond that, underpinning this mandate with a requirement for equity to be the principle guiding its interpretation. Treaty negotiators could design the provisions of the treaty to promote equity. So we could have provisions that look like these, where we designate these pandemic response products as global public goods. We harmonize the regulatory pathways and create regional hubs to produce these goods. Mandate, like in the MEAs, that resources be set aside to support LMIC's implementation of this treaty so that we can promote health equity. But there's also, another action, such as empowering the WHO as the global coordinating norm-setting mechanism to coordinate the global pandemic response, and then associating that or accompanying that mandate with a mandate for countries to refrain from practices that are inconsistent with the exercise of that function. So in instances where we have global supply shortages, countries should refrain from making advanced purchase commitments. These are all ways in which international law can be leveraged to promote health equity. This is all assuming that AMR is addressed in the treaty, the treaty could be designing this way to promote equity for global AMR policy. And finally, ensuring that the governance mechanism for the treaty has equitable representation from both high-income countries and low-income countries, and also gender parity. These are process issues, but these are things that could be incorporated in both the treaty negotiating process as well as the implementation process. Now, the key message I hope we take away today is that equity is essential for global AMR policy. We know that, right? And this is because we cannot solve the problems, because these are problems that are belied by inequity. So we need an equitable approach, an equitable solution to a problem of inequity. But we can use international law to help promote health equity. We have done it in the past in the climate space, and we can do it in the context of global health. And I think it's very important. If states are very serious about this, they can leverage lessons from previous treaties and implement those lessons in the design of this new pandemic treaty. Now that brings me to the end of this presentation. Thank you very much for listening, and I hope to take your questions.
Thank you so much, Shajoe. Thank you to the three presenters. What three amazing presentations. I want to invite you one last time to please put any questions you may have in the Q&A box, and we'll try to get to as many as we can. But it's now my privilege as the moderator to ask a few questions to get us started. And I want to start with Michèle. So as we saw from your presentation, looking at AMR in refugee and migrant populations, it's pretty complex. It depends on host and source countries and several other intersections factors. And I know that when I read literature on AMR, I often come across the term irrational use of antimicrobials, and I'm putting those scare quotes up. But your presentation makes it clear that self-medication practices, for example, it can be quite rational. So what is your reaction to reading about irrational use of antimicrobials among migrant and refugee populations?
Yeah, thanks for that great question, Mathieu. It's a really important one. I think it also speaks a bit to Dr. Rahman's question in the chat, which I saw about the role of decision-making in accessing healthcare. And first off, I think we need to remember that self-medication is a norm, and it's common behavior across all populations. So if I have a headache, I can self-medicate with ibuprofen, and that's a good thing. We don't want to have to go to the GP every time we have a bit of pain or our allergies are acting up, for example. So yeah, despite the term irrational use being so commonly used, self-medication, like my example with ibuprofen, is often rational. And this is true too for migrants and refugees. They have to make choices under constraints. And what drives self-medication, especially with antibiotics, largely is barriers to accessing formal care system. So rather than facing a big bill for an antibiotic that they can't afford or not receiving care at all, migrants and refugees choose to self-medicate. And we find ways to medicate when the formal healthcare system fails them. And I think terms like irrational use imply something very specific and negative about the behavior in question, and can suggest that educational interventions can actually do something to change that behavior. And education and awareness do have a role to play in behavior change, but the drivers of self-medication start well before that. And we can't hope to see behavior change around self-medication if migrants and refugees don't have access to adequate care. And we can't hope to see adequate access to care without universal health coverage. So I would encourage kind of looking at it through that lens rather than as this idea of irrational use.
Yeah, I mean, so often we think of these factors as being driven by individual decisions when they are fully systemic. I think that's so profound. Let me turn to Fiona next for another question. So we have a policy focus today, and your presentation highlighted how gender is driving AMR inequities and the critical importance of considering gender when taking actions to address these inequities. But I actually had a question about kind of turning it inwards to the AMR Policy Accelerator. What's the Accelerator doing to address gender and AMR inequities?
Thanks, Mathieu. I think it's a great question, and it is good to look at ourselves sometimes too. So I think if you remember from my slides, I had 2 slides talking about kind of actionable areas. The first was general actionable areas, and the second was a more specific actionable area slide. So for me, I think where the Policy Accelerator will be focusing initially is going to be on those general actionable areas. And I think these are applicable for anyone working in the AMR space as well. So definitely versatile in how they can be applied, but making sure that gender is a foundation of our research, our policy, our actions, all of our reports, making sure that we're considering the gendered impacts in any AMR mitigation actions that we're highlighting in our reports, our outputs, and that we're advocating for as well. And making sure that we're continuing to highlight gender equity in our reports, especially those that we're gearing towards other AMR policymakers and researchers, I think will be key, just to keep that at the forefront of people's minds, and to highlight that it is an inequity that should be targeted going forward. And I think by continuing to do that, we'll be identifying it as a knowledge gap and supporting research that is specifically tracking gender inequity. And as I said, that's an area where we're missing a lot of data. So by highlighting that, hopefully we'll fill in the knowledge gaps that we have in that area right now. But if we're thinking about those kind of more specific actionable areas that I showed on my specific action slide as well too, I think that we also have some experience and can support other projects and researchers who want to target these areas. For example, prioritizing gender in the next generation of national action plans, I think is a key area that we can also help support too.
I mean, just actually looking at those different intersections, both in terms of data, outcomes, and paying attention purposefully from the start, that is so important. Thank you. So let me turn now to Shajoe for another question. We know that many countries have already developed national action plans to address AMR within their borders, often with a One Health focus, and we would hope also addressing gender inequities, migrant and refugee inequities. But what's the added value of using international law to support the equitable design of AMR policies that can't be addressed by actions at the national level?
I think there are several AMR solutions that cannot be addressed solely by individual countries and equally promote global health equity. I think one clear example is the production of antimicrobials. Not all countries have the resources or the capacity to support antimicrobial research and development. So this is something that eludes the remit of some national action plans. As it is now, research and development is concentrated in and funded by high-income countries and philanthropic organizations in these countries. So to ensure that there's equitable access to these antimicrobials, international legal solutions are needed to create a global architecture underpinned by human rights principles such as equity to ensure that access meets the need. We know, for example, that low-income countries have high levels of resistance, yet antimicrobial use is higher in high-income countries. And this is something that international law can help to address through consistent stewardship rules and equitable antimicrobial distribution. So these are, this is one challenge, one AMR challenge that, eludes the capacity of the national action plans, and it demonstrates, I think, very well how international law, the added value of international law in the AMR policy.
Yeah, thank you so much for that. It's clear that this is certainly not an issue that can be addressed in one country alone, and without equitable international law, it's not a future that we want to live. So let me ask one final question before I turn to the audience. And I'm hoping for a kind of a brief response to this one. And since we're looking at equity today, I thought it'd be helpful to think about the different intersections at play. So we've heard all the presentations. You're all experts in your own fields. So I'm thinking here about the intersections of gender and migration, of international law and gender, or of international law and migration, and how they all shape equity in AMR policymaking. Just briefly, I was hoping you could reflect on those intersections or any others you may be thinking of, maybe starting with Michèle.
Yeah, that's a great question. Thanks, Mathieu. I mean, as I mentioned kind of in my own presentation, and the other presentations also talked about this briefly, but these intersections are actually really important to investigate because they can reveal some really interesting findings and really provide a lot more contextual information on what's happening and what's driving these kinds of behaviors. But I think when we think about it at the policy level, which is something that Fiona actually mentioned in terms of national action plan alignment, and remembering that those intersections need to be thought about also when we're planning and strategizing at that level. So making sure that our migration plans actually align with our antimicrobial resistance plans and align how we are addressing all kinds of different challenges within our country in our context.
And turn it over to Fiona for a quick reaction.
Yeah, I mean, just building on what Michèle said, I totally agree with everything she's mentioned there. I think, there is this huge area of overlap that's often been overlooked between these national action plans, and these resources are being divided between national action plans when there are areas of overlap. So from Michèle's presentation, obviously there's clear overlap between migrant refugees, gender issues, things like climate change, and same from my presentation. So gender, I mentioned food security as an overlap in mine. There's obviously overlap with climate change as well there. So I think by improving alignment, we're going to have, more robust action plans, and we're going to reduce the resources that we need and increase the efficiency when we're addressing multiple issues as well. So from that perspective, I think it's something that should be a focus going forward.
Thanks. And Shajoe.
I think, as Michèle and Fiona, said, it's important for us to really understand the intersections of these issues, because when we think about designing policies, we really want to ensure that the policy is informed by the best available evidence. And so that's very important. But when I think about the intersections between, the different challenges, I think that the need for and the power of law, both at the international level and domestic level, to promote equities more profoundly manifest, right? Because international law and law generally, it creates binding obligations on states and within states. And if these obligations are underpinned by human rights principles such as equity and non-discrimination in relation to the right to health, it provides persons recourse to remedies to hold the state accountable for non-fulfillment of these obligations. And so I think it's very, very, very important for us to understand these intersections, because that is critical to us designing tailored policies to this challenge, or the multiple challenges.
Thanks, everyone. And I'm sure we could keep on digging into those intersections all day, but since we do have limited time, I will turn to the audience questions. And I've seen a couple relating to decision-making, both how that decision-making happens and who is involved in the decision-making. So I'll put this to anyone who wants to take it, but do you see a role for communities mentioned, whether refugees or women in the most affected communities, in the creation of equitable AMR policy? Michèle.
Great. Yeah, I can get started. But yes, absolutely, there's a role for those communities in creating those policies. And I think there's all kinds of forms of participatory-based research approaches that add a lot of value to policymaking. And together with a lot of different social science research methods and qualitative studies, these can provide a lot of important context for what's driving these different behaviors. And they can really inform more equitable policymaking at the end of the day. Maybe I'll pass it on to my colleagues to build on.
Yeah, briefly, I'll also add, I think, exactly as Michèle mentioned, there definitely is a need to incorporate these stakeholders from across different sectors into what we're doing. And obviously, if we're not incorporating their ideas and thoughts into the process, we're going to end up with unsustainable solutions and unsustainable policies. And I think there's many examples, especially within agriculture, if we look at unintended and negative equity consequences when we don't incorporate their feedback into what we're doing. So just making sure that's a priority throughout the process will, I think, be key to making them more sustainable.
Thanks. So I'll maybe turn to a different question now. There's a question that's come in about access to formal healthcare systems. Oftentimes we talk about preserving antimicrobial effectiveness by maybe restricting access, but quite often we actually should be encouraging better access and more efficient access. So what's the role of formal healthcare systems in equitable AMR policy?
I can get started on that too. I think, yeah, our work for the Global Evidence Review on Health and Migration certainly spoke to that a little bit. I think first and foremost, we need to remember that there's also a right to care here, at least in terms of the population that I was talking about, and all populations. But yeah, there's definitely a role for the formal healthcare system in reducing the AMR risk worldwide and also improving conservation, and improving entitlements to care for migrants and refugees can actually reduce that AMR risk. And we know that two of the most important drivers of AMR are spread of infection and inappropriate use of antimicrobials, and access is clearly important to reducing the spread of infection. But as I discussed in my presentation, access is also key to reducing inappropriate use, specifically self-medication. So there's a really important role for that formal healthcare system. And as I mentioned, a lot of those barriers actually are systemic healthcare barriers. And so if we can address those, we can both address access and use issues to some extent.
Okay, I've got another, maybe a critical question coming in that Shajoe might be able to address. The issue of equitable access to antimicrobials and international law brings up actually, this might also relate to refugee and migrant populations. So it's governed by an international law system that rests on the sovereignty of states. And the sovereignty of states often leads to issues of migration leading to inequitable access to healthcare, to antimicrobials, to many other things. So can you talk about that apparent contradiction in using international law to improve migrant health when that system rests on sovereign states that may not be advancing equity among migrant and refugee populations?
This is a very tough question, but I think perennially migration, immigration, these issues have been in the domain of sovereign states. And we know, states, they exist in a state of anarchy. They jealously guard their borders. We see this manifest across the board, But I think international law, the unique contribution that it has that could resolve this contradiction is if, a human rights approach is adopted. So we have principles like non-discrimination and equity and a right to health, which is an enforceable right. These provide a unique contribution in the sense that it gives people recourse to remedies that they may not have in their local systems. And in some countries where international law becomes directly applicable, like in Latin America, etc., where it automatically becomes a part of the, the country's laws, then if you have a binding obligation, then you can try to enforce that right in the jurisdiction, in the courts, if that is a remedy that is available. I do think that international law could be limited in this context because migration has perennially been in the purview of states, and they guard their sovereignty jealously. But I do think that that is a way in which it could help to resolve that contradiction.
And I see another question that relates to the use of antibiotics in animals, which is the person who's posing the question saying limited, especially in LMICs. And is there an equity gap in terms of access to antibiotics for animal use? And what are the policy implications of that?
Yeah, I think I'll start with this. Sorry, guys. But I think that's a great question. And I think it's right to say that the data on use of antibiotics in animal is limited, especially in LMICs. And definitely, as I mentioned during my presentation, there's clearly an equity gap there. So, as I mentioned, women are less likely to have access, women farmers are less likely to have access to animal health service providers and less likely to report being able to purchase medicines like antimicrobials and vaccines for the animals that they manage. So there definitely is an equity gap there. And I think that's why addressing the fact that there is limited data available on antimicrobial use in animals and LMICs is also going to be hard. So by saying we need to be accounting for the antibiotics that are being used in animals more in LMICs by applying stricter regulations might, worsen these equity gaps that already exist. So, by implementing a regulation that prevents people from accessing antimicrobials, it might be even worse for women farmers who already have, more difficulty accessing these antimicrobials. So I wouldn't say that there's a need to, restrict this more. I always am hesitant to say that there needs to be more restrictions on antimicrobials because that can impact access and equitable access. But definitely by improving just laboratory capacity, we can monitor AMR a little more closely within animal populations as well. So I think focusing more on the other side of things, so the actual AMR outcomes can help, keep track of AMR in that population without worsening the equity gaps that are already existing there.
All right, thank you so much for that. And actually, that is the last question that we'll have time for today. It's been a really fascinating discussion, looking at international law, looking at gender inequities, looking at migrant and refugee health. There's several other presentations we could have had for this panel, but clearly equity in all of its forms is key to ensuring future access to antimicrobials in an equitable way for everyone. So I want to thank all the panelists, first of all, Shajoe, Fiona, Emdin, Michèle, Palkovits, for their excellent presentations, for responding to the questions so expertly. Thank you so much. Thank you also for attending to all the attendees, and to those watching live and to those watching a recording of this panel after the fact. We hope that you enjoyed learning about these projects as well as the types of research and advisory work that we do at the AMR Policy Accelerator. If you'd like to chat about an AMR project or a policy problem you're thinking about, we'll add some information in the chat on how you can get in touch with us. So please keep an eye out for that. And with that, I'll close this out with another thank you, and I hope you have an excellent rest of your day.
Thank you, everyone.
Thanks, Mathieu.
Thanks, Matthew. Thanks, everyone.